How's it going, guys? Past level question for 2CK surge. If you're studying for step one, got to ace 2CK eventually. This is bread and butter stuff. I'll just tell you some high points. 68-year-old dude. He's got 3-month history of intermittent claudication. Okay, it's due to atherosclerotic disease in the aortoiliac vessels, so pain in the buttocks, thighs. He's had coronary artery bypass grafting 4 years ago, so just atherosclerotic history. Smoked a pack of cigarettes daily 50 years. Obviously, that's a risk factor for atherosclerosis. Hypertension, another risk factor for atherosclerosis. Current medications, a statin, ACE inhibitor, aspirin. This triad is used in patients who have peripheral vascular disease. That's a long discussion for 2CK, but you got to know statin, ACE inhibitor, or ARB, and antiplatelet agent like aspirin. It's an important triad for patients with carotid stenosis and peripheral vascular disease. Physical exam, loss of hair over the shins. These are trophic changes. You see them in arterial disease. There's no hyperpigmentation or peripheral edema. So no hyperpigmentation. This could mean it's an important negative for venous disease. Not that it's mandatory, but I've seen NBME questions do it. Okay, when you have venous congestion, increased hydrostatic pressure in the venules and the legs, you get leakage of fluid leading to hemosiderin deposition. They can call it brawny edema. Okay, brownish edema. Peripheral edema in general, no. So at least no overt right heart failure or venous disease. And then popliteal dorsalis pedis pulses are reduced. This means we have atherosclerosis. Okay, so just another peripheral vascular disease finding. If we have venous disease, they'll tell you the pulses are normal. It's important in terms of differentiating diagnoses, because I've seen students get an easy vignette like this. They'll tell me it's a DVT. I'm like, how in the world is this a DVT? Okay, if you have venous disease, as I just said, not only is this presentation completely disparate, but just in addition, they'll tell you the pulses are normal. Okay, but this is arterial disease, not venous. And then this finding is going to confuse some people. The JVP 3 centimeters above the sternal angle. If you've been following my content, you'll know I've written this before, and this is normal. Holy shit! This isn't JVD. This isn't jugular venous distension. They'll do this in NBME questions. Students like, oh, there's JVD. This isn't JVD. That's normal. Okay. And so no overt right heart failure findings. And in terms of the test we're going to do for diagnosis here, it's just to essentially explicate that we're not looking for heart failure in this acute presentation. So which the following most appropriate next best step in diagnosis for the acute presentation being the intermittent claudication. Choice ankle, brachial indices, ABI is correct answer. So very bread and butter stuff. You're essentially comparing the blood pressure in the ankle to the blood pressure in the arm. And if the ratio is under 0.9, that's consistent with peripheral vascular disease. So you do ABIs first. After ABIs are reduced, they'll tell you in the last line, ABIs are 0.6, for instance. So after ABIs are reduced, the next step, if listed, is exercise stress test to determine exercise tolerance. If they don't list that, you're going to choose immediately exercise/walking program, exceedingly high yield for 2CK material. Okay, so don't choose answers like cilostazol, phosphodiesterase inhibitor, as your initial treatment. They want exercise/walking program. It's only in patients who are refractory, they're failing that management, you can consider pharmacology. If they list 5 drugs and they force you to choose one, obviously cilostazol is the high yield drug, but it's basically almost always wrong on USMLE. So you do ABIs first, then exercise stress test if listed. If not listed, choose exercise/walking program. Don't choose cilostazol right away. Choice B arteriography, wrong fucking answer. Now, you say, why couldn't we do this? I agree with you. I mean, it's not the next best step. And I've seen NBME do this. They'll list ABIs, they'll list arteriography, wrong fucking answer. Okay, so they like the sequence as I just discussed. Wrong fucking answer. Should I see duplex ultrasonography? Wrong fucking answer. So this is for venous disease. Okay, so if we had brawny edema, they told you the pulses are normal. And then they said there's hemosiderin-laden hyperpigmentation, those types of findings. If they give you ulcers, right? So if you have venous ulcers, those are around the medial malleoli, traditionally large slothy ulcers, whereas arterial ulcers are small, punched out on the tops, bottoms of the feet and the toes. So they like giving you ulcers as well. But then you would do duplex ultrasonography to look for venous occlusions. Okay, varicose veins, so just venous insufficiency in general, just that's when we do ultrasonography. Wrong fucking answer. Choice D, echo, wrong fucking answer. So it's not to say this couldn't be done in the future. This is if you're looking for ejection fraction for heart failure. Okay, there's no evidence of left or right heart failure here. So left heart failure backs up to the lungs. You'd have pulmonary edema, dyspnea, orthopnea, needs to sleep on pillows in bed, paroxysmal nocturnal dyspnea, wakes up gasping for air in the middle of the night. So you get pulmonary findings, pulmonary edema. Okay, so they can tell you on chest X-ray, it's just cephalization of pulmonary vessels, very buzzy phrase for pulmonary edema on NBME. I've talked about that in my PDFs. So no left heart failure. Right heart failure is going to back up not to the lungs, but to the body, right? So you get JVD, peripheral edema, sometimes hepatosplenomegaly. You get facial plethora as well. It just means decreased right heart filling. So we don't have those findings here. But echo, transthoracic is what you do when you're looking for decreased ejection fraction. Wrong fucking answer. Show AC exercise stress testing, wrong fucking answer. So as I already explicated, it's not that you wouldn't do it in this patient necessarily. I mean, clearly the patient has cardiovascular disease. If we want to evaluate further for ischemic heart disease, of course we can do exercise stress testing, but we're talking about the acute presentation, the presenting complaint being the intermittent claudication. Okay, so we've got peripheral vascular disease and we've got diminished pulses. So we're looking for peripheral vascular disease here, ABIs first, then exercise stress test if listed. If not listed, choose exercise walking program. Choice E, wrong fucking answer. You know the deal in 2 member content on steps for Appreciate your time. That's it.